Hello, I would like to thank the organisers for asking me to give this talk on peritoneal dialysis for the crash lander. I remember only too well my visit to Pakistan 2 years ago for the last PSN, and I have been following closely with Ahad how PD is growing, and certainly being able to deliver peritoneal dialysis acutely for new starters is one of the key ways of growing peritoneal dialysis and making it more available. These are my disclosures. So this is the history of one of my first patients. And I always remember him. I was newly qualified, and a man in his 50s presented with a grand mal fit at Heathrow Airport, having just arrived from South Africa. I was working at that time in the local hospital for Hillingdon, for Heathrow, and he turned up with severe hypertension, and blood tests showed severe uremia. We inserted acute PD catheter. It's probably one of the first I ever put in, and the start of my career in nephrology. And he was started on frequent manual exchanges, and he was maintained on intermittent peritoneal dialysis until a place for hemodialysis became available, because back at that time in 1973, there was a shortage of dialysis spaces in the UK. So from a historical perspective, acute PD certainly works. There is no disequilibrium. It was certainly more readily available in the days when hemodialysis resources were limited, and PD access was viewed as easier and safer than arteriovenous shunts that were then required for hemodialysis. You need to remember that central lines, even just for femoral vein cannulation, weren't available until about 1976. So the current situation for unplanned starts is really quite different. Almost all go on to hemodialysis with a central line, and this, of course, raises questions. Is this change in practice an advance, or is it something that's been driven by technology, readily available treatment pathways, and ignorance about alternatives? So let's give you another patient story. This is a 62-year-old woman who's admitted acutely with kidney failure. These are her blood tests: a creatinine of 550, urea of 33, potassium 5.8. She's acidotic and anemic. She had a previous history of a CVA from which she's made a reasonable recovery, and was living independently with no social support. She has poor balance following her stroke, and for the last few months she's been becoming more tired, and for the last week she's been nauseated and short of breath. She's hypertensive, and she has some evidence of fluid overload. So these are my questions. How would you manage this patient in your centre? Does this patient actually need acute dialysis? What non-dialysis management would you start? And how much information would you give her? Would you discuss advantages and disadvantages with different dialysis modalities at this stage? And I'm going to give you a couple of minutes to turn to the person sitting next to you. And if you're listening to this at home, just to think about yourself, how you would answer these various questions. Of course, there's no right or wrong answers to these questions, but if you are offering acute start PD, would you give an option between hemodialysis and peritoneal dialysis now or later after starting? And let's think about the advantages of acute start PD or hemodialysis for this patient. So PD as an acute start has lots of perceived advantages and disadvantages compared to hemodialysis. We need to think about the evidence, the feasibility, prescribing acute PD, and should patients give informed consent for acute dialysis modality. So let's think about the advantages of both types of treatment. So in terms of hemodialysis, pathways are well established, so easy to use. There's ready availability of acute access in terms of either a femoral line or a jugular line. There's rapid correction of biochemistry. You can control fluid removal. And once the patient is discharged, you can do this quite swiftly by putting in a permanent central line or tunnel catheter. In terms of peritoneal dialysis, it's a more gentle dialysis. It avoids disequilibrium and dialysis-related hypotension. Of course, this can be really crucially important for somebody with a previous history of a stroke. Starting on PD is a direct pathway to home dialysis. It avoids central venous access. It's possibly preferable if there's a history of active bleeding, poor cardiac function, or a recent cerebrovascular event. And really importantly, there's a higher chance of return of some residual kidney function, and therefore the patient coming off dialysis. What about the disadvantages? So in terms of hemodialysis, it's not always easy getting in central venous access. There are numerous complications, including mortality. Disequilibrium is a big problem, hypotension, infection related to central venous access, bleeding associated with anticoagulation, and the patient is less likely to receive PD as a long-term therapy. In terms of acute peritoneal dialysis, it's not possible in all patients. There's often no good pathways to PD access, so getting in a catheter may not be straightforward. There's the perceived need for patient discussions and education about PD before starting. Many people are unfamiliar with acute PD regimes. There's obviously the risk of infection, other PD complications such as leaks, and potentially longer lengths of stay. So let's think about the evidence of using acute start PD. And I'm going to go through two really large observational studies that were published about 4 or 5 years ago. They both come from China, and this one was published in PLOS One and concluded that in an experienced center, PD is a safe and feasible dialysis alternative to hemodialysis for end-stage renal disease patients with an urgent need for dialysis. This other paper concluded that urgent start PD is a safe and practical approach. Male sex and history of abdominal surgery could contribute to the development of abdominal wall complications. So let's see what these studies actually said. So the first study defined urgent start as no pre-established functional vascular access or PD catheter. They excluded people who were not able to tolerate PD catheter insertion or wait for a PD procedure, and these included people with severe respiratory insufficiency, severe acute heart failure, or severe hyperkalemia or acidosis. All patients were educated and guided, but made a decision about having either hemodialysis or peritoneal dialysis. Peritoneal catheters were inserted by laparotomy, and hemodialysis access was with femoral or jugular veins. So 79 patients were excluded and had acute hemodialysis. 178 patients entered the study, and 98 went for acute PD and 82 chose acute hemodialysis. In the acute PD group, 5 patients had dialysis-related complications, and there were 12 deaths. And in the acute hemodialysis group, there were 20 dialysis-related complications and 8 deaths. So let's look at these in more depth in terms of the dialysis-related complications, significantly more common in hemodialysis. In terms of reinsertion of catheter because of poor function, this was much more common in the hemodialysis group. Non-infectious complications such as bleeding, thrombosis, again, more common in the hemodialysis group. Malposition of the catheter was equally common in both groups. And in terms of infection, this was actually more common in the hemodialysis group. So the conclusion from that study was obviously that there was less complications in the urgent start PD. In terms of the other study, this was a much bigger study, 922 patients, all on PD. Urgent start PD was defined as PD starting within 1 week of catheter insertion, and PD was started on the day of catheter placement if there was an acute indication, such as hyperkalemia, heart failure, etc. 18% started PD on day 0 and 30% on day 1. So there's no comparison to hemodialysis in this study. But what they did compare was the complications in people starting PD acutely compared to those who started after day 7. They looked at abdominal wall complications, the most common of which were hernias and a few pleural leaks. So here again in more detail, in terms of the abdominal wall complications, the majority of people presenting with hernias needed surgical repair, and a few transferred to hemodialysis. Those with pleural effusions, virtually all transferred to hemodialysis. Again, those with hydroceles, again, all transferred to hemodialysis. And in terms of catheter complications, most of those were dealt with and did not require transfer to hemodialysis. So there's been a recently published Cochrane review comparing urgent start PD compared with hemodialysis with the central vein catheter. They're all observational studies, so the level of evidence is pretty weak, and 3 were prospective and 4 retrospective. And their conclusion, and this was only published last year, 2021, showed that urgent start PD may reduce rate of catheter-related bacteremia compared to starting with hemodialysis and central vein catheter, but uncertain effects on peritonitis risk, exit site or tunnel infections, exit site bleeding, catheter malfunction, catheter readjustment, technique survival or patient survival. 2 studies showed similar hospitalization rates between PD and hemo, and 1 study suggested a higher rate for starting on hemodialysis. So what about feasibility? I think the evidence definitely shows that urgent start PD works. That complication rate is probably either the same or slightly better than starting with hemodialysis and central vein catheters. But how feasible is it for actually starting a program of acute start peritoneal dialysis? And it's not straightforward. You do need a new pathway, and this needs some thought and teamwork. So the whole nephrology team needs to be aware that this is now an option. In terms of patient selection, you need to think about eligibility. has there been previous abdominal surgery? How much education are you going to give? And how much decision making do you have time for, and should be done before going for acute start PD. But that also needs to be put into perspective, because how much information do we give people who are starting on acute start hemodialysis? Are we giving them all the complications of hemodialysis? Are we telling them about the option of having dialysis at home and starting on peritoneal dialysis? Really key is being able to get in the PD catheter. Is it going to be done surgically? Is it going to be done by physicians, percutaneous technique? And really, for an acute start program to work, you need access to both types of catheter insertion. So both percutaneous medical insertion and surgical insertion, either by laparotomy or laparoscopy. You need an inpatient nursing team who have some expertise for peritoneal dialysis. And really importantly, they need to be aware that the patient needs to be supine in bed if starting PD urgently. In other words, they do not get up or even really sit up. And if there are periods in the day when they need to get up, they should be drained and have an empty abdomen, say before they have physiotherapy, sit out in a chair, etc., or they will have a leak and potential infection. So your medical and nursing staff need to be trained for complications. And the other aspect, of course, is being able to sustain the PD therapy until the patient or family has been trained to be able to do this themselves. So how do you prescribe acute PD? And this is really going to depend on what is available in your unit. Are you going to be using CAPD, or are you, do you have access to a cycling machine and therefore be able to prescribe APD? But absolutely key is deciding, does that patient have to start PD immediately? If you can wait even for 2 or 3 days, then you've got some healing around the exit site and therefore a lower risk of having a catheter leak. And many patients get started on acute dialysis, either hemo or PD, when this is not really absolutely needed. And in terms of the protocol, the really important thing is to use a low volume and to make sure that your patient is not constipated. If you have APD, then this can be set on the machine, but you can equally start with low volume CAPD. And those Chinese papers that I went through, people were being started on CAPD using low volumes, 2 to 700 mils, really depending on the size of the patient, and then up to full volume by 2 to 3 weeks. But as I've said, the key decision is when to start the dialysis. Does that person really have to start because of the high potassium, or can you manage that with intravenous sodium bicarbonate, use of resins such as resonium, or the newer potassium lowering agents such as Lokelma? Can you use high-dose intravenous diuretics with a fluid overload? Can you give intravenous sodium bicarbonate for the acidosis? And the high urea and creatinine themselves are rarely indicators for acute dialysis, unless there's been a really rapid recent rise. So, acute start PD is not just done in China. This is a paper that was published from Mexico in 2020 in Kidney International Reports, and goes through over 100 patients, most of whom were diabetic, with catheters that were inserted surgically and used within 4 days. And they did have a significant complication rate, but it was a very successful program, and the majority of patients stayed on peritoneal dialysis. They did have a significant infection rate of 13% within the first month, and this was associated with younger age patients, higher creatinine levels on admission, and heart failure. And people with abdominal hernias were much more likely to have a catheter leak. So finally, should patients be given how much information, and should they be having informed consent for acute dialysis modality? So firstly, people are often too sick to take part in a detailed discussion comparing hemodialysis and peritoneal dialysis. Regardless of starting acutely on hemodialysis or PD, patients should be given a choice of long-term dialysis modality when they get better. So they should be told that whatever treatment they're having, whether it's hemo or PD, that this is a temporary treatment until they're well enough and able to take part in decision-making about their long-term management. But even with education and free choice, many people tend to stay on their initial treatment because they feel that that initial treatment makes them feel better, they're familiar with it, and this is what they plan to do. So let's just go over again the advantages of peritoneal dialysis as an acute start. It's more gentle, so avoids disequilibrium and dialysis-related hypotension. It's a direct pathway to home dialysis. It avoids central venous access. It's possibly preferable if people are actively bleeding, got poor cardiac function, or recent cerebrovascular event, and a higher chance of return of some residual kidney function. And the message can only be that PD is safe and could improve outcomes for late presenters. Thanks for listening, and I'd be very willing to answer any questions.